So we're nearing the conclusion of our review series for the SCP Review Group 2025, and let's dive into hematology. So this is for anemia and blood components. So let's understand anemia. So by definition, anemia is a condition where the hemoglobin concentration in the blood is below the normal range, and this leads to an insufficient oxygen carrying capacity to meet the body's needs. And the WHO, or World Health Organization, defines this as a hemoglobin level less than 130 grams per liter in men and less than 120 grams per liter in women. So the pathophysiology, the anemia develops when the production of red blood cells or erythrocytes by the bone marrow does not match the rate of red cell loss from circulation. So the average lifespan of a red blood cell is about 120 days. And some causes fall in two main categories. So let's categorize them. First one is decreased red cell production. This can be due to nutritional deficiencies like iron, vitamin B12, folate, bone marrow disorders such as aplasia, infiltration by cancer, or chronic conditions like inflammation and organ dysfunction from the kidneys or liver. Next is increased red cell loss, and this occurs through either destruction or hemolysis or blood loss or hemorrhage. Clinical signs include it can be subtle, especially with slow onset anemia. Common signs include pallor, fatigue, and shortness of breath on exertion. And a compensatory increased cardiac output can cause tachycardia and flow murmurs. Acute anemia is usually more symptomatic, the acute one. Next is the diagnosis. It starts with a detailed history, which will include diet, medication, family history, and one good indication is your activity, your social history, and a full blood count, an FBC. Further tests include blood film examination, reticulocyte count, and measuring levels of ferritin, vitamin B12, and folate, because it might be just deficiencies on these uh, micronutrients. Let's now go to the classification of anemia in a morphological approach. So anemia is commonly classified based on the mean corpuscular volume, or MCV, as we see it on FBCs. And it's the MCV of the red blood cells. So let's go to microlytic anemia, which is indicated in a low MCV. So iron deficiency anemia. This is the most common cause of anemia globally. So a blood film shows a small or microcytic pale, so it's a hypochromic red cells and characteristic pencil-shaped cells. A low serum ferritin level confirms the diagnosis, so that's the confirmatory test. Next is the thalassemia trait. This is, however, a genetic disorder involving reduced globin chain synthesis. It features a disproportionately low MCV for the degree of anemia and normal or high red cell count. Next is anemia of chronic disease. This can sometimes be microcytic due to the reduced iron availability caused by chronic inflammation. So that's anemia of chronic disease. There should be a chronic inflammation. Next will be our macrocytic anemia, or with high MCV. First one is a megaloblastic anemia, or this is what we commonly know as vitamin B12 or folate deficiency. This results from impaired DNA synthesis, blood film shows, oval macrocytes, and hypersegmented neutrophils. Other causes might include alcohol excess, liver disease, hypothyroidism, myelodysplasia, hemolysis also causes macrocytosis due to an increased number of large young red cells, which are termed as reticulocytes. Next is normocytic anemia. Now, this is with a normal MCV. So, anemia of chronic disease, this is most commonly normocytic. It's associated with chronic infection, autoimmune disorders, heart failure, and malignancy. Next is our hemolytic anemias. This result from increased red cell destruction, and it can be congenital or hereditary. Uh, Spherocytosis or acquired, such as autoimmune hemolytic anemia. So let's go to the structure and function of blood cells. So red blood cells or erythrocytes, their main primary role is oxygen transport from the lungs to tissues facilitated by hemoglobin. No, so they are flexible disc-shaped cells that lack a nucleus at maturity. So they live for about 120 days. And let's look at leukocytes or white blood cells. So first one is the neutrophils. So these are phagocytic cells for innate immune response against bacteria. Next is eosinophils. They fight multicellular parasites and are involved in allergic reactions. So that's your eosinophils. Basophils, they participate in allergic responses, releasing histamine. Next is monocytes. So they differentiate into macrophages for phagocytosis and antigen presentation. So that's your monocytes. Next is your lymphocytes, B, T, and NK cells. So it's key to the adaptive immune response. So this is antibodies and cellular immunity. And now let's talk a little bit about thrombocytes. So essential for primary hemostasis or forming a platelet plug and contribute to secondary hemostasis, which is the coagulation cascade. Now they are cell fragments from megakaryocytes. So these are your platelets. Okay, and let's go to our essay questions. So we just have 5. We're just gonna tackle a couple or a few. So discuss the primary function of red blood cells and explain how deficiencies in key hematinics, specifically iron, vitamin B12, and folate, disrupt this process and lead to morphological classifications of anemia. So the principal function of red blood cells or erythrocytes is the transport of oxygen from the lungs to the body's tissues. Now, this is achieved by hemoglobin, a protein which contains ferrous ions with a heme moiety that binds oxygen. So, red cells also have minor roles in transporting carbon dioxide and regulating local blood flow. The production of healthy erythrocytes requires an adequate supply of nutrients or hematinics, including iron, vitamin B12, and folate. Now, deficiency in these key nutrients leads to inadequate red cell production and the development of anemia, which can be classified morphologically based on red cell size. And deficiency in iron leads to microcytic hypochromic anemia characterized by red cells with a low mean corpuscular volume or MCV and mean cell hemoglobin, which is MCH. Iron is a crucial component of the heme group in hemoglobin, and without sufficient iron, hemoglobin synthesis is impaired, resulting in the production of smaller red blood cells that contain hemoglobin. So, the blood film in iron deficiency anemia characteristically shows hypochromia or an increased central pallor, pencil shaped cells, and some target cells. Iron deficiency is the most common cause of anemia globally and can result from inadequate dietary intake, impaired absorption, increased physiological demands, or blood loss. So, in contrast, a deficiency in either vitamin B12 or folate results in macrocytic anemia, specifically a type known as megaloblastic anemia. These vitamins are essential for the synthesis of DNA. Their absence impairs DNA synthesis and causes abnormal development of erythrocytes in the bone marrow. And this results in the production of large abnormal red cells, which is the macrocytes. The blood film in megaloblastic anemia shows oval macrocytes, and the presence of hypersegmented neutrophils is a characteristic feature. So, vitamin B12 deficiency is often caused by pernicious anemia, while folate deficiency is commonly due to inadequate dietary intake. So, folate deficiency and pernicious anemia is from B12, and folate deficiency, inadequate dietary intake of folate. Now, in summary, the vital oxygen transporting function of red cells is dependent on their proper formation, which in turn relies on essential hematinics. And the lack of iron impairs hemoglobin synthesis, leading to small, pale cells, which is the microcytic anemia, while the lack of vitamin B12 or folate disrupts DNA synthesis, leading to large abnormal cells or macrocytic anemia. So, again, in that conclusion, the vital oxygen transporting function of red cells is dependent on their proper formation, which in turn relies on essential hematinics. The lack of iron impairs hemoglobin synthesis, leading to small pale cells or microcytic anemia. And then, while the lack of vitamin B12 or folate disrupts DNA synthesis, leading to large abnormal cells or macrocytic anemia. That's a good one. So, comparing contrast pathophysiology and key features of congenital and acquired hemolytic anemias. So, I'll just give these to you. Describe the functions of the main phagocytic white blood cells, neutrophils, and monocytes, and explain their roles, both the innate and adaptive immune responses. I'll let you review that. The 27-year-old woman with a history of menorrhagia is found to have persistent microcytic anemia despite her ferritin returning to normal after iron supplementation. And using the provided materials, explain the most likely underlying diagnosis, the investigation that would confirm it, and the key differentiating features from iron deficiency anemia. And the last one is a patient with a macrocytic anemia with a blood film showing oval macrocytes and hypersegmented neutrophils. Discuss the two main nutritional deficiencies that cause this picture, the underlying mechanism, and the crucial steps in their investigation and management. So if you found this useful, consider liking and subscribing in this channel, and just comment down below if you want some other topics to be covered, and we'll try to do it. Okay, see you in the next video.